All right, well, good afternoon. So today we'll be covering the 2020 review of the PALS updates. So in terms of disclosures, we have nothing to disclose, so that is nice and easy. So really our objectives today are to go through a review of the 2020 PALS updates and discuss some of the reasoning behind the updates. And to help facilitate that, we will also have a case mixed throughout that we hope that you will be keen and participate in. Um, but just as a reminder, this in no way takes the place of a formal PALS, either certification or renewal course. This is just to go through the updates that were done in 2020. So kind of some background information. So pediatric cardiac arrest is a rare event, regardless of how high acuity of a center that you work at. And thus, because it is so rare, it's important that we are keeping up with the updates that are done. And not only that, but trying to model them ideally through a simulation scenario as often as possible to keep up the skills. Is what we classify as a halo event, meaning a high acuity, low occurrence. Cardiac arrest in infants and children is usually the result of respiratory failure or shock, which is somewhat different than if you look at the etiology compared to adults. So thus, it's also important to kind of recognize the differences in the management of PALS versus adult ACLS. PALS guidelines are updated every 5 years in conjunction with the Heart and Stroke Foundation, the American Heart Association, and the ILCOR. So these 2020 updates feature some notable changes, both in pediatric cardiac arrest and in the management of sepsis.
So, a few more housekeeping things. So, just a bit about age definitions. Based on the Heart and Stroke Guidelines, they define infants as those younger than 1 year, children 1 year to puberty, and adults from those with signs of puberty. So that means breast development in females and axillary hair in males. So we thought we'd start with just a case. We're going to run through this presentation. So you have a 5-year-old boy who has a sudden cardiac arrest in your department and is brought into the resuscitation room. CPR is initiated and the decision is made to get a definitive airway. What type of ET tube should be used, cuffed or uncuffed?
Feel free to unmute yourselves and give an answer. Okay, I see a couple in the chat, cuffed, cuffed. So yes, cuffed would be the correct answer, and we will go through that in the next couple slides. So before we get to the type of tube, so this section will be about the airway and ventilation updates. The first step is looking at out-of-hospital cardiac arrest and whether or not to use an advanced airway intervention. So when they looked at the evidence, they actually found that BVM was equivalent to a supraglottic airway or intubation with an ET tube. The reason being that most out-of-hospital cardiac arrests are due to hypoxia, and therefore you want to have established effective and quick ventilation. We know that advanced air replacement requires not only specialized skilled providers, but also specialized equipment. And thus, it can be difficult to ask a professional to provide more of an advanced airway if they're not routinely performing this skill set. Um, the cons, though, of not using an advanced airway would be needing interruption and chest compressions to match the compression to ventilation ratio required, and then also just the risk of aspiration. But when you look at the retrospective trials, they've showed that endotracheal intubation and BVM achieve similar rates of survival with good neurological function and survival to hospital discharge. Thus, in terms of what to do in an out-of-hospital cardiac arrest, it would be whatever you, in terms of supplies, have available and the level of skill of the provider at that time. So in terms of what ET tube to use, so the previous 2015 guidelines actually were kind of equivocal and stated that both cuffed and uncuffed tubes were considered acceptable. The reason being is that we know that anatomically the pediatric airway narrows below the vocal cords and creates a so-called anatomic seal around the tube. And it's thought that the pressure of the tube against the airway mucosa could provide trauma to the airway and thus increase the risk of subglottic stenosis. However, when they looked at several retrospective studies as well as some systematic reviews, and they actually found that as long as you're paying attention to choosing the correct tube size, the correct tube positioning, meaning depth, and the cuff inflation pressure, your risk of subglottic stenosis is actually no higher than if you used an uncuffed tube, as long as the tube is used properly. And in fact, the benefits of cuffed tubes are that we actually can improve capnography accuracy. We actually reduce the need for ET tube changes and thus reduce the need for repeated trauma to the airway. And we can improve the tidal volume delivery as well as decrease our risk of aspiration. So in that photo there, I just have the formula to help remind you of the differences in calculating cuffed versus uncuffed tube sizes in pediatric patients.
So back to the case, an attempt is made to intubate the patient, but the airway person is having trouble. One of the members of the resuscitation team suggests cricoid pressure. What are your thoughts as team lead?
If we don't want to say it out loud, we can look in the chat as well. Yep, so I see no, maybe burp, not recommended. Good. Okay. So correct. So the previous 2015 guidelines had insufficient evidence to routinely recommend cricoid pressure. Um, it historically has been used to minimize the risk of gastric contents refluxing into the airway. So as you can see, like pressure on the cricoid occludes the esophagus, theoretically reducing risk of reflux. However, there are concerns that the tracheal compression might actually impede your first pass success at intubation. So the new 2020 guidelines actually don't recommend routine use of cricoid pressure. They actually do recommend considering the use of burp if your primary concern is actually a view and first attempt success. So if we go to the next slide. So a reminder, just burp would be a specific maneuver done to help improve like a difficult airway by improving the visualization of the larynx. So it's backward, upward, and rightward pressure. It's more reliable, and in pediatrics, it's actually easier to find the thyroid cartilage versus the cricoid. So this would be the recommended method if you are struggling with obtaining an adequate view.
Back to the case. A burp maneuver is used and intubation is successful. What is the ventilation rate of the intubated patient during CPR?
Note takers. Okay. So first we'll talk about assisted ventilation in patients with the pulse before we get to that last question. So the previous 2015 guidelines looking at infants and children who have a pulse but inadequate respiratory or absent respiratory effort recommended one breath every 3 to 5 seconds, which would equate to approximately 10 breaths per minute. The new 2020 guidelines actually recommend increasing that rate to about a breath every 2 to 3 seconds, which is about 20 to 30 breaths per minute. The reason being kind of what we've alluded to in the previous slides is the cause. So when you look at pediatric causes of cardiac arrest, the most common is hypoxia. So you want to ensure that you're having an adequate ventilation oxygenation rate, and the 20 to 30 breaths more appropriately matches what a physiologic respiratory rate would be in that age group. Okay, so if we go to this next slide, so this is assisted ventilation with an advanced airway, meaning they're receiving compressions and you have either a supraglottic or an endotracheal tube. So just to review what is on paper before getting into the why part of it. So they previously recommended a rate of every 6 seconds, and they changed it to match what the previous slide was, which is one breath every 2 to 3 seconds. If you were to look this up at all, you would find the words controversial, hotly debated, questionable. If you're looking into like any review articles, podcasts, there's a lot of chatter about this. The reason being they looked at the actual evidence that they pulled up to support this change. So it's based essentially on a single center study done at a PICU over a course of 3 years. It only incorporated 47 patients. And essentially, it's just a different population than what you would typically see come through pediatric ER or especially an out-of-hospital cardiac arrest, then coming into an ER. All of these patients were already intubated. 60% had congenital heart disease as their underlying diagnosis, and three-quarters of them actually first had bradycardia with poor perfusion that then progressed into an in-hospital cardiac arrest. In all of these patients, none of them actually were ventilated according to the PALS guidelines at that time, which was 10 breaths per minute. They were all ventilated at a higher rate. So there was no like direct comparison. And all the patients who had a shockable rhythm, they survived, and all the patients with a PEA systole, none survived. So the big critique is that is this generalizable to a population that we're going to see in our ER or like in the community in a smaller hospital or like EMS arrival on scene? Probably not. The tricky part also is we need to consider matching our ventilation to perfusion. So yes, while most causes that we will see are hypoxia related, we need to make sure that we're still supporting their circulatory system. And we know that with PPV, we are decreasing like blood pressure, you can decrease cardiac output and potentially perpetuating the circulatory collapse. So the American Heart Association and the Heart and Stroke Foundation, and obviously like PALS, has adopted this change. But interestingly, Alcor, for their guidelines, did not adopt this change. So while we are in no way recommending that you do not follow PALS, this is a review, and the review is to do a breath every 2 to 3 seconds. The the underlying message is just consider the etiology of the rest of your patient. And that remember, you're trying to match ventilation to perfusion needs and just trying to balance the need for oxygenation with cardiac output, essentially. And then just a final reminder that CPR without an advanced airway, those guidelines were unchanged. So single rescuer is 30 to 2, and two-person would be 15 to 2.
Okay, back to the case. Now that this 5-year-old child has a definitive airway, let's turn our attention to the management of their circulation. What compression rate would you use? And I can't read that rest because you're covering it. And at what depth would you do compressions? So let's talk about circulation. So it's obviously important to recognize when a cardiac arrest has happened and immediately initiate high quality compressions in order to generate good blood flow to the vital organs and increase the patient's chance of spontaneous circulation. The guidelines define 5 components to high quality CPR. This is adequate chest compression depth, optimal chest compression rate, minimizing interruptions, so less than 10-second pauses, avoiding excessive ventilation, and allowing full chest recoil between compressions, no leaning. The AHA guidelines are quite specific about the no leaning. They cite that studies in animals have shown that incomplete chest recoil or leaning on the chest after chest compression motion is complete markedly reduces the perfusion pressure to the brain and the myocardium, which leads to adversely affecting survival rates. So we are going to talk about each one of the components of CPR. So the first is the depth of compressions, and according to the guidelines, it should be a third of the anterior posterior diameter of the chest. So in adults, 5 centimeters is ideal, no more than 6 centimeters. In children, it's 5 centimeters, no more than 2 inches. And in infants, it's 4 centimeters, no more than 1.5 inches. I thought this was a good diagram by Lurie K. et al., published in Anesthesia and Analgesia in 2016. And I'd like you just to look at the compression depth graph, which shows that your optimal compression depth of 50 millimeters or 5 centimeters gives you the best probability of survival to discharge. Okay. So going forward, installed. So let's talk about minimizing interruptions. Cunningham and all published some good graphs in their article, which shows, as in this one, when you're compressing, you're at a good perfusion pressure with high quality CPR. The moment you halt, you drop your perfusion pressure so that you're no longer perfusing anything. And it takes about 10 compressions to start to adequately build back up to an adequate perfusion pressure. This is a direct comparison, which shows that when your compressions halt, it takes time to resume back up to good perfusion pressure. And the more you halt, the less amount of time you spend at adequate perfusion pressure, as opposed to B, which shows that compressions without interruptions, you maintain that perfusion pressure for longer periods of time and hopefully giving your patient the best possible outcome. So back to the case. At pulse check, you have the compressor change out and someone new begins compressions. The new compressor is compressing at a rate of 100 beats per minute. Is this fast enough? So compression rate was one of the changes in 2020. The old recommendations recommended anywhere from 100 to over beats per minute. The new recommendations are quite specific, and a frequency of 100 to 120 compressions per minute is optimal. And obviously remember to use a hard surface. If you look at the evidence behind this, so Lurie, K, and all in their publication in Anesthesia and Analgesia show that the best probability of survival is from 100 to 120-ish beats per minute. Interestingly, the PALS guidelines is based on a small observational study by Sutton and all, where they found a compression rate of at least 100 beats per minute was associated with improved systolic and diastolic blood pressure during CPR in hospital cardiac arrest for pediatrics. But there's a little bit of controversy in this article as well. So this study looked at three different groups. One was kids who had a compression rate of 80 to 100 beats per minute, the guideline rate of 100, and those who received greater than 120. And they found that in those that were above 120, when compared with the guidelines, did have a lower systolic blood pressure and were less likely to survive. But those with a lower compression rate from 80 to 100 actually had improved survival when compared to the guidelines. Um, but they advise caution because their lower compression rate group was only 8 patients, and the median rate of compression was 95 beats per minute, which they said was pretty close to the 100 beats per minute. So what can we take from this? Um, Basically, compressing and decompressing the chest too rapidly, greater than 100 beats per minute, reduces the venous time below what is needed to refill the heart. So you have poor outcomes. But in a resuscitation situation, best to follow the guidelines and aim for that 100 to 120 beats per minute. So the next change from the 2025 guidelines was epinephrine administration. The old guidelines from 2015 said it was reasonable to give epi in pediatric cardiac arrest. The newest guidelines state for epi, the preferred route is IVIO over your endotracheal tube administration. And you need to administer epi within 5 minutes from the start of compressions, and it's reasonable to give every 3 to 5 minutes. So why so specific? Why within 5 minutes? Well, this recommendation was based on a few studies. One of the ones I'm going to present here was Anderson et al., and they did a time to epinephrine and survival after pediatric in-hospital arrest, published in JAMA in 2015. So they analyzed patients in the Get With the Guidelines resuscitation registry, and they looked over a period of 4 years. It was an observational study, but they included 1,588 patients. And they found that in those who were delayed in receiving epi, they had decreased chance of survival to hospital discharge decreased ROS, decreased 24-hour survival, decreased survival to hospital discharge with any favorable neurological outcomes. So time to epi is important. Some other medications we just thought we quickly note is that for shock refractory VF and VTAC, amiodarone or lidocaine may be used. Routine administration of sodium bicarbonate is not recommended. Of course, the exception being in hyperkalemia or sodium channel blocker toxicity, example in a TCA overdose. Routine administration of calcium is not recommended in pediatric cardiac arrest, the exceptions being hyperkalemia, hypocalcemia, calcium channel blocker overdose, or hypermagnesiemia.
So before we go into this next section, is there any questions about the first portion? Not, we will continue on.
There is a question.
Oh,
Sorry, I
where do
have
you
a
see it?
question for that. So I know,
Okay.
like typically in the shock situation, it's sometimes not accessible to have like IV at the first when we'll start the CPR, and that's possibly the ET would be the only route for the initial epi dose. But my questions is like after if we introduce like ET dose, still it is the 5 minutes for the IV dose, or it varies.
So you can give epi after 3 minutes. So if you have the IV access and it's the 3 minute mark, you can give your IV or IO dose in that time.
Okay. So even after like for the ET dose to the next dose as epi dose, IV or IO, so 3 minutes still that we need to wait, right?
Yeah.
Okay. Thank you.
All right, so then we will move on to the next section, which is looking a bit into shock. So PALS not only updated their shockable versus non-shockable algorithms, they also had a few updates in regards to managing septic shock. So previously, I think we were all familiar with the standard give a 20 cc per kilo bolus. In 2020, they did make a recommendation that it would be reasonable to administer fluid boluses in 10 to 20 milliequivalents with frequent reassessments. So they're not saying depart from liberal fluid resuscitation. The reason being that it is just you're more likely to develop clinically significant fluid overload if you are to repeatedly administer 20 cc per kilo boluses, and it might obscure your ability to determine is there another underlying component going on to this patient's shock presentation. So they're just recommending smaller doses, just more frequently with more frequent assessments. And this also could be a good opportunity, not a discussion for today, but an opportunity to utilize POCUS skills potentially for fluid reassessment after boluses. Just as we know that fluid overload can worsen multiple different outcomes and can also increase a need for mechanical ventilation if your patient is not already requiring that. So in terms of vasopressor choice, previously in 2015, dopamine was recommended as the first line to treat shock that is unresponsive to fluid resuscitation. And I think most of us are now familiar with that. In the new 2020 guidelines in children and infants with fluid refractory shock, it would be more reasonable to use either epinephrine nor norepinephrine as your initial vasopressor choice. But however, if you're in a center where these are not available to you, then dopamine can be used. The reason they found it is that when they looked at it, epinephrine is more effective than dopamine in improving for fluid refractory hypotension in cold shock and improved organ function when they looked at it within the first hour of resuscitation. And then we looked at longer term outcomes, so 28-day mortality, they found better rates of resolution of shock and survival as compared to dopamine. So these would be your preferred agents.
So we know it's important for family to be present during their child's resuscitation. And these guidelines reaffirm that. And because we're pediatricians, we thought we'd take a moment just to talk about the family. So most parents indicated that they would actually like to be present for their child's resuscitation. And there's been qualitative studies, which I won't go into today, which show benefits to families if they are present during the resuscitation of their child. Parents have reported that they believe that their presence helped bring comfort to their child, and being present also helped parents to begin to grieve the loss of their child. Being present helped parents understand what was happening and to know that everything was being done for their child. There was no evidence for arguments that family presence causes trauma to the family, interferes with the procedures, impacts the technical performance and decision making of the team. It is beneficial to have a designated team member to provide comfort and support to the family, as well as to help answer questions that the family might have during the resuscitation. So back to the case. Your team achieves ROS. What are the components of the post-arrest care?
Does anyone have any thoughts what might fall into that component of the pediatric chain of survival as indicated by the arrows? Okay, we will tell you. So just taking a moment to look at this slide. So the pediatric chain of survival has two chains. The top one being the in-hospital cardiac arrest and the bottom being the out-of-hospital cardiac arrest. They're both fairly similar. Really, the difference is looking at, in terms of in-hospital, early recognition and prevention, versus the out-of-hospitals looking more just at prevention. This would be things such as like appropriate use of seatbelts, appropriate use of helmets and bicycles, the speed in school zones, things like that. So what can we do to potentially prevent the arrest from happening? And then what was new to this guideline was the addition of something called the post-cardiac arrest care link. Um, Really, this is to stress the importance of recovery. And this is not only focusing on the short term, such as recovering this, surviving the arrest and recovering to discharge or being discharged from an ICU level care, but also looking at long-term treatments and evaluations, as well as supports for survivors and their family, because we know that post-cardiac care arrest doesn't just end in the hospital. So this is a new, I know it's really small. I couldn't find a way to make it larger and fit the screen. It's more to highlight that this is an algorithm that, or a checkbox rather, that was created by PALS to help guide the components of post-cardiac arrest care, because there really prior to this wasn't a great like check sheet to help you remember. So I'm not going to go through each and every component of it, but we will touch upon some highlights. So in terms of targeted temperature management, there's kind of two methods of it. So they do recommend doing continuous measurement of your core temperature and then aiming either for a temperature of 32 to 34 degrees Celsius for 48 hours, followed by 3 days of normothermia, or just 5 days of normothermia. Really what you're trying to do is trying to avoid hyperthermia, so fever, as you don't want to increase the metabolic demand any further at this point. In terms of blood pressure management, they recommend keeping the systolic above the 5th percentile for age to avoid hypotension, as you want to maintain not only cerebral perfusion pressure, but also end organ perfusion. If you are in a center that has the skills and the availability, the most accurate way would be to monitor this with an arterial line. And then going into ventilation and oxygenation management. So ideally, in terms of oxygen, you would like to target normal oxemia after ROSC, but keeping in mind that it needs to be appropriate to the child's specific medical condition. Meaning if, for example, they are a child with single ventricle physiology whose SATs in the community sit at 80 to 85%, this is what you're trying to target. We're not aiming for normal saturation goals of in the 90s. In terms of the target CO2, again, ideally aiming for normal capnia and trying to limit exposure to severe ends of either hypercapnia or hypocapnia, as we know that that has effects on cerebral perfusion pressure. However, keeping in mind that there are many kids with underlying complex medical conditions that do tend to sit with things such as chronic hypercapnia, and we do need to take that into consideration when setting our goals. The other things that they have recommended, the American Neurological Society as well as Canadian, is if your patient after cardiac arrest remains in a persistent encephalopathic state that you cannot really otherwise explain, they do recommend the use of continuous EEG if available, to look for things such as non-convulsive status epilepticus, as they do recommend treating both non-convulsive and convulsive status epilepticus in the post-cardiac arrest period. And the other thing that they really stress the importance of is, beside all of the immediate medical things that we just touched upon, the others that are in that check sheet, is evaluating cardiac arrest survivors for rehabilitation services. So this is not just your medical, but also things like OTPT, caregiver supports, community supports, and recognizing the risk that they have. They have a pretty high risk of some sort of neurodevelopmental impairment, particularly in kids who already have underlying complex medical conditions. So screening them and connecting them with the appropriate follow-up, not only for the short term, but for the long term, but also recognizing the role the family plays in this, and the stress and caregiver burden that can occur, and making sure that they are also supported in the community, and recognizing what community you are sending them home to and what might be available to them. I think sometimes in tertiary centers, we live in our little bubble where we have access to everything, but recognizing that if we're sending someone home to a more remote location, that perhaps it might take some more time and resource setup to get them to a point where they feel comfortable being at home.
Okay. So our take-home messages today, in summary, is high quality CPR remains the foundation of resuscitation. Use a cuffed ET tube in place of an uncuffed. Avoid cricoid pressure. Respiratory rate of 20-30 breaths per minute for CPR, an advanced airway, or those who have a pulse and are receiving rescue breaths. Compression rate of 100 to 120 per minute with a max depth in adults of 6 centimeters. 5 centimeters is ideal. First dose of epi given within 5 minutes to increase the odds of survival. Smaller initial boluses of fluid for septic shock. Epi or norepi is preferred over dopamine. And consider the family presence in the resuscitation room. And don't forget the post-ROSC care. These are some of our references. And we thank you very much for coming. And if you have any questions, please don't hesitate to ask.